yeah, I feel like it's worthwhile, and I like to listen to people's problems and try to give them some direction so that they do have a healthy, long life, and it pays off. There's always those times when people come back and appreciate what you did for them, or sometimes you don't even know what you did for people and they come back and say, you know, you remember, and you don't even remember telling them that or giving them that advice, and they come back later and thank you for that, you know.
I can rephrase that. I would say that for any career, what satisfies people is, I mean, I think in clinical careers, it's the patient interaction, and that's a kind of amazing relationship that you kind of manage to develop with, you know, meeting different people and taking histories, and that kind of thing is incredibly valuable. But it's the how to rephrase that? It's personal development and a level of autonomy, a level of sort of self, of being able to sort of improve oneself and reach actualization.
There was a 60-year-old patient who came here with stroke signs, came with an ambulance, and I started managing him. I asked the secretary to hold the CT. I talked to the neurologist. I didn't wait for someone to take him. I took him myself after doing the examination. And we went straight to CT. And I met the neurologist at the CT. And after doing the CT, we decided to take him straight to the stroke unit and give him treatment. So in the evening I got a nice call from the hospital which said that there's no neurologic deficit. So
the differences I've seen regarding clinical associates and doctors is that we are more clinical based with be it our management of patients, even our studying is more clinical based than it is with doctors. Doctors, it's mostly books and everything, like read everything, do everything, but I feel that they're never really taught to apply it to the real life setting. So that's what I feel the big difference with us is, because I mean, I worked in my final year and BCMP, I worked with some final year medical students, and the level of knowledge that we had compared to them, ours was very much patient based. Like we knew that no, go get a good history, talk to your patient, build a rapport with your patient. Whereas them it was more of, oh, the book says I need to do this and this and this. You know, that's what I noticed. But I mean, I wouldn't have first-hand experience on that. Yeah.
We have people we do, like they survive and some don't, and even if they don't, then there's so much trust they have in you that you can help them guide to their death, to their dying. Yeah, so that's what I do like about my job.
And by you telling them that you that is talking to them is also a survivor, he was in the same state they are in currently, and they walk out from the ETU and they are back, you know, psychologically is a kind of huge, you know, positive impact, all right? They feel that, you know, they can also be like you. And so our roles in there was actually to encourage, you know, to encourage patients that you can make it, you know, you need to be strong, you know, you need to have the faith that you can make it.
So that is where we do. So all the great vessels are chopped off, and the last to be cut out is the left atrium. So that is the posterior here, if you can see this area. So this roof part of it is left behind, and just at the level of pulmonary veins, we chop all the pulmonary veins and take out the heart. That's how we do it.